Diabetic ketoacidosis, DKA, generally occurs in type 1 diabetics but can also occur in type 2 diabetics. Some 95% of presentations are type 1, the remainder type 2. Why can we see it in type 2 diabetics? Well, let's appreciate DKA actually occurs due to a lack of insulin. Type 1 diabetics are unable to make the insulin. Synthesis of insulin is inhibited due to defects, of course, as you understand it. Type 2 diabetics, however, in the later stages are unable to produce insulin because the beta cells of the islets of Langerhans in the pancreas that produce insulin have undergone exhaustion and therefore are unable to produce the insulin either. So therefore, they resemble type 1 diabetics in a pathophysiological standpoint. Now, in terms of presentation, patients will present with polyuria, polydipsia, and non-specific abdominal pain and discomfort. Why do we get the polyuria and why do we get the polydipsia? I'll explain in a moment. The abdo pain discomfort is due to the excessive glucose, i.e. the hyperglycemia, causing irritation to the peritoneum. We'll also see why we get the hyperglycemia in a moment too. Now, let's understand the fact that there's a lack of insulin. Insulin actually opens the GLU4 receptors on our cells, and therefore we have an uptake of the glucose from the serum. Because there's no insulin, the GLU4 receptors are not open. This leads to increased levels of blood sugar, i.e. the serum glucose levels. Serum glucose levels need to be in excess of 11 when we measure them on a random, so 11 millimoles. We also have, because of the lack of uptake of glucose, we also therefore have reduced glycolysis in the cells, i.e. cell respiration slows down. That in itself will lead to some level of fatigue or lethargy, but the lack of glycolysis will also contribute to the hyperglycemia. Now, because of hyperglycemia, we're going to end up with osmotic diuresis. We're going to end up weeing a lot. That excessive weeing is what we call the polyuria, and that will cause volume depletion in the extracellular fluid, and therefore that will lead to dehydration. The other impact of a lack of insulin means that we're going to have an increased amount of lipolysis occurring, because what needs to happen is we still need to gain energy. So what happens, we get the breakdown of fats. We have an increase in the fatty acid concentration in the plasma, and we also have an increase in the hepatic free fatty acids. All of this causes ketonemia. Now, we will look at ketones. If we were to measure it in the serum level, that should be equal to or greater than 3 millimoles, or on a urine dip, it should be 2+ or more. The other thing what will happen as a result of ketonemia or ketosis is that we'll have an increase in the amount of glucagon being released by the alpha cells of the islets of Langerhans in the pancreas. Now, in doing so, what we've done is we've already actually given some of the diagnostic criteria for DKA. That was a random glucose measuring greater than 11 millimoles, ketonemia measuring 3 or more on the serum or 2+ on the urine dip, and we now need to also measure the bicarb and the pH. Because of the ketosis, what happens is the ketones, which are keto acids, these are neutralized by buffers such as bicarbonate HCO3-. What happens is, because the HCO3- is now busy buffering this acidity, it'll deplete the reservation of HCO, so we will get a drop in bicarb ions. And on diagnostic criteria, that needs to be bicarb of less than 15 millimoles. And finally, because of the ketones and the dehydration, what we'll have is some acidosis. And again, on a blood gas, that needs to measure less than 7.3. So the criteria, 3 usually is what we suggest, but otherwise I would say 4 ketones, 2+ on urine dip, or 3 or more on the VBG, glucose measuring more than 11, pH less than 7.3, and bicarb less than 15 millimoles. These are your diagnostic criteria for diabetic ketoacidosis. Okay. and you've understood why. So now again, if you appreciate the diabetic diuresis, the osmotic diuresis is what's going to, with the volume depletion, the osmotic diuresis is going to cause a polyuria, and that volume depletion is going to cause the polydipsia. So there are your symptoms explained. Now, what we will see is a high anion gap metabolic acidosis, just for completion. So how are we going to manage this? What we need to do is we need to resuscitate. We need IV fluid resus. So we need to add in some IV fluids. We will add in normal saline with potassium. The normal saline needs to be administered slowly. Why? Because what will happen is feed too much water in too fast into the serum. We will reduce that hyperosmolarity. So the solution, so let's talk in terms of osmosis, keep it simple. The serum osmolality, or osmolarity, I might just refer it to here, is going to decrease. So it's going to be very dilute once we add the fluid resus in. If that becomes too dilute too fast, it will be more dilute than the concentration of the cells, the osmolality of the cells. So therefore, by osmosis, water will move in from the serum into the cells. Now, for the most part, that's not too much of an issue, except if and when it occurs in the brain. If you do that, you'll get cerebral edema. So that's why we need to do it very, very carefully and very slowly. So generally, we will introduce 4 to 6 liters over a 24-hour period. Because we're going to introduce water, we're going to cause hemodilution of some of the ions. The main ion we need to worry about here is potassium for 2 reasons. First, because of the hemodilution. Secondly, because of insulin. Remember, we are going to administer insulin in this patient as treatment as well. Insulin will do 2 things. It will rectify the hyperglycemia because insulin lowers the blood sugar levels. But what it also does is, as much as it will open the glucoreceptors and allow the intracellular uptake of glucose, thus correcting hyperglycemia, it will also promote and stimulate the increased intracellular uptake of potassium. So you will get hypokalemia if you're not careful. So for that reason, when we do the fluid resus, we need to watch the potassium levels. So monitoring of potassium levels every 4 hours is very, very, very important to prevent hypokalemia. So the insulin will drive intracellular, will promote intracellular drive of potassium, and the fluids will rectify the hyperglycemia. Fluids too fast, too soon, and you'll cause cerebral edema. What we will do is, once the BMs drop less than 14, we will add in some IV dextrose. And what we want to do is we want to prevent hypoglycemia. So the IV fluid resus is going to correct the hyperglycemia. Yet again, if it's done too fast, too soon, will result in hypoglycemia, and so we need to just control that a little bit. So the insulin, when we give it, initially we'll give a fixed rate until we balance out the levels and the ketosis and the metabolic acidosis are rectified, which indicates that you need to perform the blood gas. So there's a blood gas on the back of which we looked at the criteria. Once your metabolic acidosis and your ketosis has corrected, then we can go from fixed rate insulin to variable rate insulin. So there you have criteria for DKA. Do the blood gas, have a look to see whether there is DKA or not, or is a patient at high risk if they're type 1 diabetic. Don't take any risks. Let's administer the fluid resus, let's administer insulin, let's monitor the potassium levels, and let's administer some dextrose to prevent the hypoglycemia. I hope that helps. Thank you for watching.